In these two cases, weight was the strongest correlate. So the take-home message really for this section is that perhaps there is in fact no best measure of anthropometry to use with regard to cardiovascular assessments, and it may depend on the question that one is asking. However, most of our studies are collecting or will be collecting longitudinal measures of adiposity, and I hope to show you that longitudinal models have perhaps more value in the type of research questions we are asking. In the RAIN study, we calculated adiposity Z-scores from 8 time points between birth and 14 years of age using CDC standards. Growth trajectories were then calculated using a technique of semi-parametric mixture modelling. This is a technique which allows one to identify latent patterns of longitudinal development. The optimum trajectory model is shown here. It was decided based upon the Bayesian information criterion. You can see that along the x-axis is age in years from 0 or birth up to 14 years of age, and along the y-axis is the adiposity Z-score. The red group, or the red line, represents a group which has a trajectory of approximately an adiposity Z-score of approximately 0 throughout life. In other words, they were of average adiposity from birth at every time point until they were at the age of 14. This group comprised 31% of the population and was deemed to perhaps represent optimal normal growth, and for future reference will be used as the referent group. There were two groups, labelled here 1 and 2, shown in yellow and green, which reached a high final adiposity. The yellow group reached had a chronically high adiposity throughout life. The green group reached a high final adiposity but was rising from an average birth adiposity. Two groups reached a moderate adiposity at age 14 years, one falling to this adiposity and another rising from below average birth size. I'll refer back to these trajectory models later in the talk when we discuss the applications of cardiometabolic risk assessment. We now move on to discussing how we can assess the metabolic syndrome in childhood. As we know, obesity doesn't occur in isolation. It occurs within a cluster of abnormalities, a cluster which includes hypertension, dyslipidemia and insulin resistance, and has previously been coined as the metabolic syndrome by Reven. Obesity is one of the major factors driving this cluster in adults and children. There are multiple consensus definitions for the metabolic syndrome, particularly born out of the World Health Organization, the National Cholesterol Education Program, and the International Diabetes Federation. As you can see, the consensus definitions all vary slightly in terms of the particular cutoffs used, and it's important to emphasize that these cutoffs are in fact arbitrary. They are also ethnic specific, and the use of adult cutoff points is simply not appropriate to directly translate to childhood studies. Therefore, in an attempt to try to avoid using arbitrary cutoffs, we use a technique. In addition, as testament to the fact that there is controversy in defining the definition of metabolic syndrome in children, you can see a study here now several years old showed at the time that there are over 40 unique paediatric definitions for the metabolic syndrome, really testament to the fact that there is no consensus. So, as I said, in an attempt to avoid using these arbitrary cutoffs, adult cutoffs, we used a technique called two-step cluster analysis, which uses continuous variables to identify a group of children with features very similar to the metabolic syndrome. We used the cluster components of body mass index, systolic blood pressure, fasting triglycerides, and homeostasis model of insulin resistance. This was undertaken in the RAIN study at ages 8, 14 and 17 years. I'm going to show you the data from the 17-year-old follow-up. Here you can see the high and low risk clusters. The following slides are all of identical format. The high risk cluster is shown on the right-hand side and comprised 18% of the children or the young adults at 17 years. You can see that they have significantly higher BMI. The mean and 95% confidence intervals are shown, with a difference on average of 6 BMI points, a higher waist circumference with a difference on an average of over 15 centimetres, and a higher systolic blood pressure, homeostasis model of insulin resistance, fasting triglyceride, C-reactive protein, and as one would expect, a lower level of HDL. Similarly, cluster analysis had been undertaken at the 14-year-old follow-up, and you can see the high and low risk clusters here. Once again, the high risk cluster is on the right-hand side, the low risk cluster on the left-hand side, and you can see that the high risk clusters have significantly greater BMI, HOMA, triglycerides, waist circumference, systolic blood pressure, and lower HDL. And in fact, even at the 8-year-old follow-up, there was wide separation of the high and low risk clusters. I just draw your attention to the fact that the 95% confidence intervals are widely separated. There is no overlap whatsoever, indicative that these are very disparate and distinct groups. Having now covered many of the variables and measurements which will have been universally and are collected in population cohorts, I'd like to move on to discussing a sampling of different cardiovascular markers or tests which can be used and have been in children. In the interest of time, it won't be possible to discuss them all comprehensively, but I hope to give you a flavour of the potential tests which could be used. Other cardiovascular risk markers would include inflammatory markers, lipids, non-alcoholic fatty liver disease, markers of subclinical atherosclerosis, including arterial stiffness, intermedial thickness and flow-mediated dilatation, as well as retinal vasculature. C-reactive protein is probably the most well-known of the inflammatory markers related to cardiovascular disease, and there is a great body of adult literature showing that elevated CRP is associated with subsequent cardiovascular risk and cardiovascular endpoints. However, this has also been seen in children. Here is a study now, 10 years old, which shows that elevated C-reactive protein levels were associated with early arterial changes in healthy children. This data out of the RAIN study shows that those in the high-risk cluster on the right-hand side had significantly higher levels of CRP, but also gamma-GT and alanine aminotransferases, both markers of liver inflammation, as well as elevated uric acid. Other inflammatory markers which have been investigated in the RAIN study and have been associated with the metabolic cluster include interleukin-18, TNF or tumour necrosis factor receptor 1 and 2, as well as the adipokines, adiponectin and leptin. As I mentioned earlier, obesity doesn't occur in isolation. It occurs with a metabolic syndrome. However, metabolic syndrome doesn't occur alone either. It occurs with other conditions such as non-alcoholic fatty liver disease. NAFLD, or non-alcoholic fatty liver disease, is often considered by many, particularly hepatologists, to be the hepatic component of the metabolic syndrome. It is in fact the most prevalent liver condition worldwide, and the development of NAFLD is intimately related to key components of the metabolic syndrome. You can see this data out of the RAIN study, which shows the presence of NAFLD on the right-hand side and absence of NAFLD on the left-hand side. Those with NAFLD have significantly greater waist, systolic blood pressure, triglycerides, C-reactive protein and a lower HDL, a very similar picture to that seen with the metabolic cluster. Another measure of subclinical atherosclerosis is that of arterial stiffness, and one methodology which has been used in the past to measure arterial stiffness is that of applanation tonometry. Arterial stiffness has been shown in adults to predict cardiovascular events and mortality independent of other traditional risk factors. This has been shown in adults, but also in children, particularly those at high risk, including obese children and children with familial hypercholesterolemia.